correction, I'm an orthopedic surgeon, by the way. So I'm the odd one out here. And the transcameron approach is quite popular in our part of the world, and now it is being extended to all these fusion surgeries. And OLLIF is the new in thing now in our part of the world, basically because it is much faster, safer, and much more predictable for the patient. And I'll be sharing my presentation, and you would all be surprised to know that in my hands and in our part of the world, we are doing surgeries like OLLIF under local anesthesia and conscious sedation. And because ours, like Dr. Abasi said, are resource restricted countries, we don't have things like neuro monitoring. Patients are very reluctant to go to ICU, and we have patients with all age factors and cost factors. So this is a surgery which is particularly useful, and I'll be sharing some of the tips and tricks and showing how we go about this. Short presentation for the tips and tricks and how we go about this under local anesthesia. These are the routine cases which we kind of see daily in our practice. Single level anesthesis, and everybody is out for their lives, and these are all surgical candidates. I think everybody and every one of us are sure about this. Most of these patients, some of them do quite well for while on conservative. Some require surgery, but those in between who are not responding to conservative and who are, not fit for surgery, for general anesthesia, maybe, high risk group of patients with cardiac diseases and chest diseases, etc. So can we help those kind of patients as well? So, or are these patients without any hope? So this is how we do it in our setup. The preparation for the patient starts in the pre-operative room itself, so that we have low amount of time the patient spends in the OR, because we find that a conscious and a awake patient starts to get panicky in an OR environment. So we try to do all the pre-medications well in the pre-operative room, and this also makes the surgery quite efficient and cuts down on the OR time. So the pre-op medication 5 to 10 minutes before shifting the patient to the OR. Now we have the painkillers and the regular pantoprazole, tramadol, etc. Catheterize the patient in the pre-op itself. The ECG stickers, cautery pads, the IV cannulas, epidural tube, if it is all needed. It can even be placed 1 day prior, so that least amount of OT wastage time is there. Sensitivity testing, vital charting, everything else is done in the pre-op itself. So patient is made prone, and I like to do this procedure under prone. There are some centers who are doing under lateral, but I'm really uncomfortable doing that. And we check compression over the eyes. The patient is made very comfortable. Neck position is checked. Patient is asked repeatedly that whether he is lying in a comfortable position or not, because you find that the surgery in itself is so painless that a patient doesn't feel anything, more or less. But if he's uncomfortably positioned, they start to fidget, and then it starts creating a problem in the OR. So forearm is placed over arm support, upper limbs are secured, axilla is padded, bolster is at the chest level. All these are regular things, but the patient is cushioned and made very comfortable on the OR table. And so as you can see, the patient is secured with the strap. Uh, so the patient is secured with the straps, etc., so that he doesn't move a lot, and he has a very restricted fear of movement during the surgery. And it is not that he's very uh, tightly tied down to the surgical table and make him uncomfortable for that. So you can see here, this is the tape which I apply over the epidural line sometimes when it is needed, so that I can paint and drape over this as well, and I secure the arms, etc. Again, lightly tied, so that the patient doesn't make uh, you know sudden movements. And I like to keep the lower limbs free, so that I can see that the movement of the limbs is there, because we are not using neuro monitoring in our setup as the patient is awake. And you see how the abdomen is completely free. This is a Jackson table which I use, so that there's no pressure over the abdomen and the patient is quite comfortable. And sometimes in these obese patients, you see even the Siam picture is not that clear. So for that, we have this trick where we use the tapes, etc., to just mobilize the fatty part of the body away from the surgical level of interest, so that the Siam picture then tends to improve. So this is how you see, just lifting up the abdomen and securing it with tapes, and you see at the end, the picture is much improved, and you can, well identify the landmarks for the surgery. So again, patient electric warmer I use so that the patient is comfortable again. The Siam, we sometimes use single Siam, and now after Dr. Abazi's visit, we have now started using double Siam, and I tend to write all these angles on the Siam with the tape, so that my X-ray technician doesn't forget and doesn't have to, fiddle with the X-rays too much. He just reaches the position, again mark the Siam position on the floor as well. And this is how it looks like with a dual Siam setup. And this is the anesthesia protocol which we use. We use just a local infiltration of 5 ml of lignocaine with adrenaline, 10 ml of sensoricane and NS. Dextrometamidine infusion is used for sedation and also for lowering the blood pressure of the patient. We use IV fentanyl bolus dose at really painful parts of the surgery, and a little bit of medaz as an anxiolytic dose rather than a sedation dose. And if needed, especially during the part of screw placement, we can do an epidural, short-acting sensory epidural as well. And these are the instrument sets which we use, and routine targeting of the level. All this is well aware. So this is another case, the which I showed, endofusion, pain in the back, radiation to lower limb with the SLR 20 degrees, MRI showing listhesis, and you can see the stenosis there. And this is the dual Siam position, and you can see here that this is the short surgical video I made, and it is also available on my YouTube channel. And you can see that the patient is well awake, and she's quite comfortable. When we are doing the surgery, the patient is awake, and they tolerate it quite well. The last patient I did, the movement of the patient was so much that I couldn't see anything under the CR. And then I realized that the patient was so comfortable that and asleep that she started snoring on the table. And then I had to time my CM shots with the, end of expiration and inspiration so that I can get an image. You can well imagine how comfortable the patient gets. And now again, local anesthesia, again for the screws. You can see the patient is well awake. The standard technique of the Jamshedi needle, the guide wires. And this surgery under local anesthesia truly makes this an outpatient procedure. The patient is sent home by evening or morning next day. So I'm just skipping the video in the interest of time, because this is just regularly the screw placement. And you can see the guide wires, the taps, everything is being done under local anesthesia. And even the rods passage, everything under local anesthesia. And then at the end, the reduction towers are removed. So this is how the final construct looks like in the AP view. And these are the transverse screw incisions, because I find these are more cosmetic. So I've started giving transverse incisions, the rod insertion incisions. And for the cage and even the bone graft, we just harvest it under local anesthesia with the help of power trifines and drills. And this is the immediate post-op. And by evening, we mobilize the patient as tolerated by the patient. You can see she's very, very comfortable. So this is the question we always get: can we do adequate disc preparation? And I hope this is this picture shows that an adequate disc preparation has been done. And will it crush the exiting room? So you can see in this video, this is the cage, and how as it goes, it just slides under the exiting nerve root and just pushes it out of the way. And since the patient is awake, we are sure of what we are doing, and we are not doing any neurological damage. So this is another question. So will it fuse? This is a 55-year-old male with the listhesis at L5S1. You can see the listhesis there. This is the MRI. And again, the fusion which we did. And after 2 years, this is the CT scan. You can see it has fused beautifully well inside the cage as well and outside of the cage as well. So a lot of graft is being packed outside the cage also. So another, is it just good enough for one level? So this is a case L3, L4 listhesis and reduced disc height L4, L5. Did a 2 level again under local anesthesia. Another case, listhesis and reduced disc height, 3-level fusion. You can see on the dynamic X-rays the amount of instability and the MRI showing the compressions. And this is the construct again done under local anesthesia. And this is the post-operative MRI, and you can see that the indirect decompression immediate post-op is quite well. You can see here all the levels are quite well decompressed by the indirect decompression there. So another case, this was a case in which he had a adjacent segment disease and he was fused at this level by an open surgery. So we had an option of going in again, opening it up and then again fusing it. But the patient was not very suitable for the general anesthesia. And we decided to do again the OLLIF. And this is a strategy we took. We just did one level above and bypassed the entire construct so that we didn't have to open. And this is the post-operative picture. You can see this is the scar of the previous surgery and the scars which we had given this patient. You can see the big difference there. And again, this patient was a cardiac case and had some chest problems, and he was absolutely not fit for any general anesthesia. So the take-home message that transcambin fusion is safe, effective, and very efficient. So the fastest which I have done is under 28 minutes, skin to skin. And we do it under local anesthesia. It is now a very efficient technique in our hands. Careful patient selection and thorough knowledge about the procedure is mandatory. And if indirect decompression can work from the front, it can surely work from the back as well, like I have showed in the cases. And we always have the option to use an endoscope or a tube or whatever if you want for a direct decompression as per the demand of the case, which we can do it in the same sitting if we are doing it under general anesthesia, or maybe do it in a second stage as per the circumstances that allow. Like to thank Dr. Abbasi for coming all the way to India last year and pushing the procedure and generating the procedure.
I would like to add just say my greatest thank to my Indian colleagues.